Go.
So good evening and welcome everyone. I'm Dr. Sayali. I'm the junior consultant and fertility specialist at Oasis Fertility Pune at the Karadi Center. So today we have come up with another Facebook live session, and the topic for today is what's new in the thin endometrium treatment. So endometrium is like the innermost layer of the uterus. It is a tissue that lines the inner layer of the uterus, and it is essential in terms of pregnancy. It's because here that the embryo, after getting formed, it gets implanted, and the further growth of the embryo takes place here. So there are two hormones, basically the estrogen and progesterone, that is required to prepare and to thicken this endometrium, and to help in the process of implantation. So as the pregnancy advances, the embryo that is implanted, it needs to be nourished and the baby needs to grow. So all the nourishment is supplied by the glands which are present in the endometrium or the inner lining of the uterus. So when there is absence of adequate growth of the endometrium, so when the endometrium is not properly thickened at the time of implantation, or when it doesn't have an adequate blood flow, it is difficult to attain or to sustain this pregnancy. Now there are basically three important factors that affect the growth of this endometrium. First, we have, as we have seen, that the two important hormones are the estrogen and the progesterone. So when we have low levels of estrogen in the serum, or we have decreased blood flow to the endometrium, or we have a endometrial tissue that is unhealthy. When there is an history of any infections, any inflammation, any trauma to the endometrium. Now this trauma can be in the form of any infections which causes inflammation and scarring of the endometrium, or it can be because of any past surgery that has caused damage to the lining of the uterus. That's basically a dilatation and curettage procedure that is done for miscarriages or the induced medical termination of pregnancies, or procedures that like a uterine myoma that has been removed, or a polyp that has been removed. And there is a factor which indirectly also affects the thickness of the endometrium, and this is the woman's age. So as the woman ages, the estrogen levels are going to kind of then the estrogen is not going to act well on the endometrium, and therefore the thickness of the endometrium and also the blood flow to the endometrium is going to be hampered. So coming to our question is, how thin is thin endometrium? There is no definitive cutoff as to what the thickness of the endometrium is to be considered, but most of the studies has considered an endometrial thickness of less than 7 mm to be associated with decrease in the implantation and decrease in the clinical pregnancy rate. So studies have shown that the implantation, the clinical pregnancy rate, and overall obstetrical outcome is better in individuals who have an endometrial thickness of greater than 7 mm. But it is not only the endometrial thickness that matters. It is also the pattern of the endometrium. So we require a proper triple line endometrium, where we have the outer and the central line, which is going to be hyperechogenic, and the central portion is going to be dark or hypoechoic. And this triple line endometrium gives a greater chance of pregnancy. That is a type C endometrium, rather than endometrium, which is like a homogeneous or an irregular pattern of the endometrium. And then also comes your blood flow to the endometrium. So there are zones in the endometrium where the blood vessels actually reach. So it does, the blood vessels need to reach the central line of the endometrium, that is the innermost portion of the endometrium. So it's when the blood vessels reach the zone 3 and the centermost area, that is the zone 4. It is only in these individuals, that the proper nourishment is delivered, proper blood flow is there, and therefore the chances of pregnancy is there. So as we have seen that if the endometrial thickness is less than 7 mm, there are decreased chances of implantation and decreased chances of attaining pregnancy. An ideal endometrial thickness is anywhere between 8 to 12 mm, but the chances of pregnancy implantation are very low if the endometrial thickness goes less than 6 mm. Now, coming to what are the causes of this thin endometrium. So as we have seen, if is like when the estrogen levels are low, when the serum estrogen levels are low, they are not going to act on the endometrium, and the endometrial thickness and the blood flow is going to be less. Next is the inadequate blood flow. Now the blood flow to the endometrium may be affected in individuals, with obesity, who have a sedentary lifestyle, who do not exercise, if there are presence of any factors in the endometrium which are going to, hamper the blood flow, like the presence of a fibroid or polyp. Now these are going to, impact the endometrial blood flow. The next is the poor health status of the endometrial tissue. So when we have, conditions such as infections, such as the sexually transmitted diseases, the pelvic inflammatory diseases, now tuberculosis, this is, basically going to cause inflammation of the endometrium and followed with scarring of the endometrium. So this scarring is going to, obliterate the endometrial cavity, and this is going to decrease the blood flow to the endometrium, and therefore it will result in thin endometrium, and an endometrium which will not have an adequate blood flow. That is, the blood vessels are not going to reach the the zone 3 or the 4 of the endometrium. Then comes the iatrogenic trauma. That is, if any form of surgery is done on the endometrium, that as we have seen, like the curettage procedure, in induced abortions, or in, individuals who have had previous miscarriages, or procedures such as myomectomy, or, a polypectomy, or individuals following a delivery, if they have an adherent placenta and the placenta has been removed, this will kind of cause scarring of the endometrial tissue, damage to the endometrium, and this will result in like adhesion formation in the endometrium, and they are going to obliterate the endometrial cavity. Next cause of thin endometrium is individuals who are taking these birth control pills, like which contain the estrogen and progesterone for a very long duration. These individuals also have thin endometrium. Then, when we're using ovulation induction, drugs like clomiphene citrate, this can also increase the incidence of thin endometrium. And certain systemic conditions, such as individuals with diabetes, hypertension, individuals with asthma, those who have a history of, epilepsy, history of any depression, substance abuse, like, excessive cigarette smoking, these conditions also increase the incidence of thin endometrium. And certain of these conditions can be idiopathic, like we don't know the actual reason, but these individuals, they have a thin endometrium, but these individuals, despite having a thin endometrium, can have, a good pregnancy result, because the blood flow and the pattern of the endometrium is good in these individuals. So how does an individual with thin endometrium present? So when this individual comes in an infertility setup, they usually complain of having painful menses. So the periods are going to be painful. They're going to have irregular periods. So in these individuals, the endometrium is not well formed. So when the thickness of the endometrium is not well formed, there's not going to be adequate shedding. So they are going to have a condition known as hypomenorrhea, or they're going to have scanty menses, or sometimes they even have irregular or delayed periods. Or in conditions when there are adhesions, where there's Asherman syndrome, when the cavity of the endometrium is obliterated, these individuals can also present with amenorrhea, or absence of menses. Again, because the endometrium is not getting formed well, these individuals, they have a problem in conceiving, and they present with infertility. Or some of these individuals can be asymptomatic. So the condition of thin endometrium is, usually diagnosed only on a routine sonography, or when a hysteroscopy is done for some other condition. So when these individuals with thin endometrium come to you, is it possible to attain pregnancy in these individuals with thin endometrium? So as most of the studies have said, that an ideal endometrial thickness is 8 to 12 mm. So if your endometrial thickness is less than 7 mm, if there is an obstructed blood flow to the endometrium, or if the pattern of the endometrium is not good, it is associated with decreased implantation rate. And these individuals, even if they conceive, they have very increased chance of early miscarriages, or later on in the pregnancy they have an increased incidence of developing PIH, then low birth weight, small for gestational age, or early deliveries. So for successful pregnancy, if these individuals are going for an IVF cycle, what we can do is we can give them a hormone replacement therapy followed by a frozen embryo transfer. So there's the possibility of attaining a proper pregnancy will be better in these individuals through an HRT. Now, how can you diagnose an individual with thin endometrium? So usually, when the patient comes to your setup, these patients, as we have said, they can present with irregular periods, scanty menses. They can come with infertility, or in some conditions, they will be infertile. So the diagnosis can be done with the help of a transvaginal sonography. So a transvaginal sonography will help us to know the thickness of the endometrium. It will help us to know the pattern and the endometrial blood flow. Next comes your hysteroscopy. So when a hysteroscopy is done, for diagnosis of, a case of infertility, or when they have other conditions such as a fibroid or polyp, in that case, when a hysteroscopy is done, it will show us the, pattern of the endometrium. It will show us the presence, the amount of endometrial blood flow, the paleness of the endometrium that is there, or conditions such as fibroids or polyp that can kind of affect the endometrial blood flow. Then there are other procedures such as a curettage or a biopsy, in which an endometrial tissue is sent for the lab analysis. And when this tissue is sent for lab analysis, it will give us the exact reason as to what is the cause of thin endometrium. So the diagnosis, as in, is it because of any form of infection, or is it because of any fibroid or polyp that is there, or is it because of adhesions? The reason for your thin endometrium will be known through a curettage or a biopsy of the sample. So now we have dealt with what is the cutoff for the thin endometrium. We have dealt with the diagnostic option, how these individuals will present to you. Next coming is the treatment option that is available in individuals with thin endometrium. So first we have is the low dose aspirin. So low dose aspirin is basically a vasodilator. Means it's going to dilate the blood vessels, and it's going to cause an increase in the blood flow to the endometrium. So studies have shown that there is an increase in the implantation and increase in the clinical pregnancy rate. As we know that it is not only the thickness of the endometrium that is important, but also the blood flow to the endometrium. So aspirin is going to help in increasing the endometrial blood flow. Those studies have shown that aspirin has no effect on increasing the endometrial thickness. Next is your vitamin E, that is tocopherol. Now, this is an antioxidant. So now what it is going to do is it's going to scavenge the reactive oxygen species or the inflammatory cells, and it is going to, increase the blood flow to the endometrium. Next is your pentoxaphylline, which is a vasodilator. Now, this will also dilate the blood vessels. It increases the blood flow. It decreases the platelet aggregation. So it decreases the viscosity of the blood. So the proper blood flow is maintained, and thus decreases the inflammation. So the pentoxaphylline, along with the combination of vitamin E, can kind of, increase the endometrial blood flow. Next is your sildenafil. Sildenafil kind of causes the nitric oxide release, which is a vasodilator, and this also increases the blood flow to the endometrium. L-arginine, it is also a mediator of nitric oxide. So it has an action similar to sildenafil, and this is going to also increase the blood flow. Next comes your estrogen therapy. Now, as we know that the hormone estrogen is very important, which will act on the endometrium and help in increasing the thickness and the overall blood flow of the endometrium. So we can give estrogen in the form of estradiol valerate, in oral form, or the vaginal estrogen can be given. This basically is going to increase the this endometrial thickness, and it is going to increase the blood flow to the endometrium. So this has shown to increase the implantation, the clinical pregnancy, and even the live birth rate in individuals. Then comes your indirect. Now, the estrogen supplement will, include giving this estrogen directly to the individual. Now, when we are doing ovulation induction, or when we are, giving them gonadotrophins in the form of HMG. Now, this is going to act on the gonads, and this is going to cause the secretion of estrogen. And this estrogen will then act on the endometrium and kind of increase the endometrial thickness and the blood flow. So this is an indirect form of estrogen therapy. Then we have other methods such as regular physical activity that kind of increases the metabolism, it increases the blood flow, yoga, then electrical stimulation. Then acupuncture therapy has also kind of shown to improve the blood flow to the uterus. Then we have herbs and other natural supplements that are present, such as the royal jelly, the flax seeds, the red clover that is present, the wild yam, or the evening primrose oil. And next option that we have available is endometrial scratching. Endometrial scratching is like, causing intentional trauma to the endometrium. So when endometrial scratching is done, what it does is it causes the release of the growth factors, and it causes the release of cytokines. So it kind of induces an inflammation in the endometrium. This also increases the blood flow, release of many growth factors, cytokine mediators, and this kind of increases the chances of implantation and increased chances of the clinical pregnancy rate. Now, these are the treatment options available for thin endometrium that we have seen right now. So there are some, newer treatment options or newer modalities of treatment, most of which are, still under investigation, but a few studies have shown them to be effective. So in that, we have HCG in the treatment of thin endometrium. Now, HCG, that is a human chorionic gonadotropin, when we use it in low dose, that is 150 international unit of HCG, when given for a period of 7 days in the proliferative phase of the menstrual cycle, along with the other therapies such as the estrogen that you're giving or the sildenafil that you're continuing, along with that, when you give HCG, when this HCG priming is done for a period of 7 days, they have shown that they have shown that there is an improvement in endometrial thickness and the receptivity of the endometrium, and this has shown to increase the pregnancy outcome. Next treatment modality that is available is the GCSF, that is the granulocyte colony stimulating factor instillation in individuals with thin endometrium. So individuals which have a refractory endometrium, like those who are not responding to the usual treatment that is available, so we can give GCSF to them. It is a type of colony stimulating factor, and this plays an important role in follicle development and ovulation and implantation. Now, what is it going to do? It is going to stimulate the endometrial stem cells, or it is going to mobilize the bone marrow stem cell, which is going to result in promoting growth of the endometrium. So basically, we have 300 microgram of GCSF, which can be given subcutaneously or intrauterine slow infusion after assessment of the endometrial cavity after the 9th or 10th day. Now, if you feel that the endometrial cavity has not, but the thickness is not adequate or the blood flow is not adequate, after the assessment on the 9th or 10th day, then you can, give an intrauterine or a subcutaneous GCSF 300 microgram. Now, here the intrauterine GCSF has found, to have a better efficacy than the subcutaneous dose. But the effective dose of GCSF, what is the exact day of administration, and what is the possible effect on the pregnancy rate, the studies are still to be done, and there is no conclusive evidence that is present. Next comes your PRP. PRP is basically your platelet-rich plasma. Now, in this process, 10 ml of the blood is drawn from the patient. Then you centrifuge this sample and you prepare a platelet-rich plasma. And of that, 0.5 to 1 ml is instilled directly into the uterine cavity. So when this individual with thin endometrium is going for a fresh transfer, then you can, instill a 0.5 to 1 ml of PRP in the uterine cavity 48 hours prior to the embryo transfer. And when it is a case of a frozen embryo transfer, then you evaluate the uterine cavity, the thickness of the endometrium, the blood flow on the 10th or the 12th day of the cycle. And if you feel that the endometrium is not growing adequately and the vascularity is not adequate, then you can instill 0.5 to 1 ml of the sample into the uterine cavity on that day. Then you can reassess the endometrium after a period of 3 to 5 days. And if you feel that, the results are not very appropriate, then you can, repeat the PRP installation. Now, what does PRP do? PRP usually has around 4 to 5 times the platelets that are present in the normal blood, that's in the circulating blood. So they are going to induce your cytokines, they're going to induce your growth factors like your vascular, endothelial, epidermal, fibroblastic growth factor. And these are, they have an important role in increasing the endometrial receptivity. They increase the implantation rate, they cause growth of the endometrium, they kind of increase the vascularity of the endometrium, so they increase the implantation and the pregnancy rate. Then the treatment that is available is a peripheral blood mononuclear cell or the stem cell treatment. So now these two options are like the last resort and they are experimental. But many of the studies have shown that the installation of the peripheral blood mononuclear cells have shown to have a significant impact on increasing the endometrial thickness and the endometrial receptivity. So again, the peripheral blood mononuclear cells, these are going to kind of, induce the proliferation of your cytokines, your growth factors, the interleukins. So what are they going to do? They're going to increase the endometrial thickness, they increase the receptivity of the endometrium, and they increase the chances of implantation and increase the clinical pregnancy rate. Again, if it's a fresh embryo transfer, then 2 to 3 days prior to a fresh embryo transfer or after assessment of the endometrial cavity on 8 to 12 day, you can instill these peripheral blood mononuclear cells into the uterine cavity. Now, coming to the stem cell, usually the bone derived stem cells are used in individuals who have the damaged refractory endometrium. So, despite all the treatment modalities that are available, if these individuals are not responding to anything, if the endometrium is remaining thin, if the vascularity is poor, then these bone marrow derived stem cells can be instilled, and then we can, move ahead with the treatment in these individuals. And if the endometrium thickens adequately, then we can move ahead with the transfer in these individuals. Okay, so I hope that whatever discussion we have had till now is going to be helpful to these individuals, who are facing this problem of thin endometrium. So even though like you're not able to conceive, or you have problems of irregular or scanty menses, you have to understand that there are many treatment options available. There are many options with which we can help you to conceive and make your fertility journey successful. So I think this is all that I have from my side. Let us see if we have any questions coming over from our viewers. Okay, so the question that we have is, what is the best treatment for thin endometrium? So as we have already discussed, that the newer treatment modalities that can be in the form of HCG, PRP, or be it GCSF or stem cell, these are all experimental. Though certain studies have shown that the peripheral blood mononuclear cells and HCG is found to be effective, but more research is needed. So the best treatment for thin endometrium is to use this thing, sildenafil, that will kind of increase the blood flow to the endometrium. And next will be to use your estrogen supplementation. Okay, the next question is, what happens if the endometrium is thin? So as we have seen that the cutoff for the endometrium is 7 mm. So if the endometrium is less than 7 mm, and to be precise, if it is less than 6 mm, it is not adequately formed. So it is not going to, help in the process of implantation. Even if implantation occurs, there is going to be increased risk of early miscarriages. So the nutrition, the support that is needed to the embryo that is implanted, because all the the glands, the endometrial glands and stroma, that is going to provide nutrition to this baby that is formed. So if the endometrium is not going to adequately support that, so either you will have no implantation and a failure of pregnancy, or if the implantation does occur, there is going to be increased risk of miscarriages. Or if you're continuing your pregnancy, then in that case there is going to be an increased risk of pregnancy induced hypertension, IUGR babies, and complications further on. Okay, so the next question is which medicine is best for endometrial thickness? So as we have seen that the most proven is estradiol valerate. Now you can use estrogen in the form of oral supplementation, or you can use it in the vaginal form. Other medications which kind of help to improve the vascularity to the endometrium, such as your low dose aspirin, sildenafil. These are kind of the best medicines for improving the endometrial thickness. Okay, so the next question is what is the natural treatment for the thin endometrium? So natural treatment for thin endometrium is initially, daily physical activity. Then, when we have this acupuncture therapy or the electrical stimulation, these therapies kind of improve the blood flow. The yoga, meditation, these kind of improve the blood flow to the endometrium. Then we have things like the flax seeds. We have the red clover, we have primrose oil, we have the royal jelly. These kind of can improve the endometrial blood flow. Having a diet which is rich in antioxidants like green leafy vegetables, these things can kind of naturally improve the thickness of the endometrium. More so, they improve the blood flow to the endometrium. Okay. So the next question is how can I thicken my endometrial lining in 48 hours? So I think that's a very tricky question. How can you thicken your endometrial lining in 48 hours? It is a little difficult. So, the most of the treatment options that we have seen kind of, take a longer duration. We require a multiple modality of treatment. We need to use the, treatments that kind of increase the blood flow to the endometrium. That's your aspirin, sildenafil. We need to use the estrogen supplementation. If that is not effective, then we need to go ahead with PRP, HCG, GCSF, and everything. So I think the best thing out here will be you can just go ahead with the PRP, or you can go ahead with the GCSF treatment. And then you can see whether there is an improvement in a period of 48 hours or no. Okay, so thank you everyone. I think this is all that we have. So I would like to conclude my session here. So if you have any queries relating to this topic or any help needed from us, you can dial the helpline number that is given below, or you can meet us at any of our two centers, that is Oasis Fertility at Kaspate Vasti in Bakad or Arisa Avenue at Kharadi. Thank you.